Congressional District, and we're here this morning to do an update regarding a piece of legislation that is moving rapidly through the House of Representatives, and obviously has great interest, certainly to folks who are flyers here at the Senior Center, but frankly, it's an issue that cuts across all age groups in terms of healthcare costs. We've got some great panelists here, and we're going to try and run through again quick summaries in terms of just the various perspectives that they bring to this issue. And I thought I would just again start out by just sort of doing a quick summary of HR 3, which is the Lower Drug Costs Now Act, which again, in terms of legislation, this bill has not only been introduced, but it's also there have been public hearings, and there's been markups, as we call it, in committee, and votes to report the bill out of committee, which it has all happened really within just the last 3 weeks. And again, I get asked a lot, is anything else happening in Washington right now? But this is clearly a measure that is moving forward, and that's why I thought it was important to just kind of give a quick rundown to folks, because it is going to directly impact a lot of the people that participate here at the Convenes Senior Center. Again, I want to first of all thank Mary Jo Riley for hosting this here today at the center this week on a fairly regular basis. This is an outstanding senior center. There are many in Eastern Connecticut, the 64 towns. But I, again, just think that herself and her team do great work in terms of obviously providing all the services, but also the information for folks. And this morning is certainly another example of that. So HR 3, which is the Lower Drug Costs Now Act, as I said, has been reported out of the Education and Labor Committee, which I sit on, the Energy and Commerce Committee, and the Ways and Means Committee, all of which have sort of jurisdiction over healthcare issues. Is a bill that I think is definitely very much responding to the public's very loud message that what's happening in terms of drug prices is just unacceptable and has to be addressed. If you look at the exit polls from last year's 2018 election, which was the largest voter turnout in a midterm since 1914, the exit polls listed healthcare costs, and particularly prescription drug costs, as the number one issue that they were looking for action in Washington, D.C., and appropriately so. So we've got some slides here, which hopefully we can go to the next slide.
Hold on, I'm circling around the back.
Okay. And let's do the click here. And again, this is not going to be death by PowerPoint. I'm going to do 3 slides, and then we're going to hand it off to our friends here. So first slide, again, just shows facts which I think most people know intuitively, if not specifically, which is that we pay the highest prices for drugs anywhere in the world. The list price of more than 3,400 drugs just in the first 6 months of 2019 increased by more than 17% from last year. I mean, a stunning figure, which far surpasses any rate of inflation for any other commodity or service. From 2011 to 16, prescription drug spending in the U.S. grew by more than 2.5 times inflation. In Connecticut, and we checked with the insurance department in the state of Connecticut to ask what's the impact in terms of premiums for health insurance overall. It shows that the amount that prescription drugs consumed in the average dollar of premium that employers pay or individuals pay has grown from 15% in 2010 to 23% in 2019. 23% of the premium dollar is more than gets spent on doctors, hospitals, medical equipment, any other component of healthcare services is less now than the 23% that gets consumed to pay for prescription drugs. And again, it was a report released by the House Ways and Means Committee, which shows that prescription drug companies charge Americans prices that are roughly, it's at on average 3.7 times the cost of identical products in other countries. Next slide. So the Lower Cost Drug Act now does a couple of things which I think are really very significant, and again, lots of input from folks who work on this issue, both in terms of academia as well as stakeholders. And I know we have folks here who are real life individuals that have to deal with this challenge. Number one, it directs the Secretary of Health and Human Services to negotiate the price of up to 300 prescription drugs, which again is now prohibited by law. There was back in 2005, the Medicare Part D law actually has what's called the non-interference clause, which by law prohibits the government from negotiating better prices for prescription drugs. That is not the case in the Veterans Administration. The VA negotiates prices. As many of you know, we obviously have a high veterans concentration here, and as a result, the amount of money that the VA pays for prescription drugs is far less by unit cost than Medicare. Medicare, by the way, will be the largest negotiating pool of any health program in the U.S. and frankly most of the world. Okay, so we're basically conceding a lot of leverage in terms of trying to basically get a better price. And as we all know, if you shop at Costco or Sam's or whatever, buying in bulk always gives you better prices. Charging drug manufacturers, so that's number one. Number two, it charges a rebate if they increase the price of their drugs faster than inflation. Number three, and this is obviously a very significant one for seniors, which it caps the out-of-pocket costs for seniors on Medicare Part D at $2,000. So if you're on Medicare Part D today, and even with closing the donut hole, if you are taking an expensive medication, we know, and Judy and others who deal with patients pay a lot more than $2,000 in terms of out-of-pocket costs. I was talking to a retired teacher from Killingly the other day. She has an AFib condition. She takes very expensive medication. She's on Medicare Part D. She pays $13,000 a year out of pocket because of the fact that there's no cap now on Medicare Part D for the co-payments. And if you have a very expensive drug, those co-payments go through the roof like her. I don't know how she balances it because her teacher's pension barely covers the same amount. And lastly, the bill was scored by the Congressional Budget Office. That's the scorekeeper in Washington, and they determined that in terms of the savings to Medicare Part D alone, and again, the Medicare pays for Part D drugs. It pays, and there's other savings which they still haven't calculated because they're trying to get the numbers straight. But just in Part D alone, is a $350 billion savings over 10 years. And when you think about the fact that Medicare right now in 2026, according to the trustees, is going to start tipping into negative territory in terms of its finances, having a $350 billion savings will help stabilize the program and hopefully open up opportunities to address other problems that exist in the Medicare program. Last slide, which I just sort of want to, I don't know if you can see it back there, but again, it is a graph which shows the per capita spending the U.S. has today compared to other countries. And again, it kind of starkly shows the fact that that line, the red line at the top, is we're number one, which is kind of an unhappy position to be in. Again, it's about $1,200 per capita. That's every man, woman, and child in America. A lot of them don't take medication at all. Versus Canada, which is next in the red lines, France, and the last one is Mexico. But there's little gray lines that are all the other countries there. So again, we're in a situation, we're an outlier that, as I said, when people were showing up at the polls in 2018, and this was bipartisan, there was no party line thing about prescription drug costs. This cuts across everybody's districts. And that's why I think HR 3 is been introduced and is moving forward the way it has. An organization which has been very active in terms of getting communication and dialogue out there in Connecticut and in this part of the state is AARP. Some of you may be members of AARP. Nora Duncan is to my left, who is the state director. And again, I'm going to yield the floor, as they say, to her to give some thoughts in terms of her perspective. I'm here with Judy Stein from the Center for Medicare Advocacy, who has been around for 40 years now, helping patients deal with the Medicare program for free, by the way. And has done just amazing work and obviously has had, run into this issue personally and professionally over and over and over again. And lastly, Laura Hawk, who's from the National Multiple Sclerosis Society, again, whose patients, again, have to deal with high cost of medications, and as a patient advocate that does great work across the state of Connecticut. So, Laura, the floor is yours.
Thank you, Congressman. Thank you, everyone, for being here. So, how many of you have struggled with the high cost of prescription drugs or know someone who has? Okay. So that's why we're here, right? The U.S. paying the highest prescription drug rates in the world is a big problem, especially since as taxpayers, we actually fund a lot of the research and development that goes into these drugs through our tax dollars. So it's not your imagination, as the Congressman pointed out, if you think you're paying more now than you were before. I have a lot of stark and slightly terrifying statistics, a couple of which I will give you, just to kick things off, and then I know we're going to do Q&A after. So in Connecticut, the average annual cost of a prescription drug treatment increased 57.8% between 2012 and 2017, while the annual income in Connecticut increased by only 12% over that same 5-year period. In 2016, in Connecticut, 21% of people stopped taking their medication because they could not afford it. Not because they were just being, then there's those that just don't do what their doctor says, right? But this is, I cannot afford my medication. And between 2012 and 2017, the 3 top drugs for the 3 top you don't have the money to buy your prescription drugs, you are not going to get better. Or you're going to do things like, I'm sure Judy could, and you could talk about, which is, leave the hospital and then end up back in the hospital within 30 days because you weren't able to take on your course of treatment. All of which costs our healthcare system money that is really not necessary to spend. So I'm going to pass this back to you now.
Thank you, Laura. Judy.
Thank you so much. It's always good to be in the Brockton Senior Center, which is one of the loveliest ones around this state. And with the Congressman, one of the things that strikes me as I looked at that slide with the graph, hard as it was to read, no problem. That was rude. What I meant was when Medicare is often the lead in what happens in healthcare and insurance. When Medicare public dollars pay those increasing costs, then most people on private insurance start to see those increases happening as well. So this affects most Americans, and we should be in much more the mode of the Veterans Administration, as the Congressman said. We know that I was told back in 2006 that the Secretary didn't have the capability of negotiation, and I suggested to CMS at the time that they could get the capability, and that obviously Walmart doesn't negotiate on behalf of the Groton store and then the London store and et cetera. They negotiate in general, and Medicare has the largest patient pool to negotiate on behalf of. This bill, H.R. 3, is our first real chance at getting that to happen. That's the first beauty of the bill, is to negotiate drugs. I think it's 300 in this go-round, very important drugs that would be negotiated. And as the Congressman said, that would save us, the estimate is, and I say us because this is all paid by us, $345 billion over 10 years. That's a lot of money. I remember when we were calling for this 10 years ago, they were suggesting that it would be $150 billion over 10 years. So it's a lot of money. And so the first 2 messages are, this is a wonderful bill because it gets rid of the thing that's not. It will require negotiations. Number 2, it will save $345 billion Number three, it will put that money back into Medicare, which is dearly needed, and into the traditional, I'm beginning to think of it as calling it the real Medicare program that affects at least 2/3 of everybody in Medicare, so that people in Medicare will all be benefited, both in the reduction in the cost of the medications and in improvements to Medicare, which could include things like an oral health benefit and some oral health, vision, and audiology benefits, and other things that we hope that this money would allow to come to Medicare, which is dearly needed. So there's a bunch of wins in this one bill, and I applaud you for being part of moving it forward.
So multiple sclerosis, or MS, like many other chronic diseases, patients face astronomical costs for their drugs, and they only continue to rise. You'll see on the charts to the left and right of the stage just how quickly they've risen over the last 20 plus years. The MS disease-modifying therapies between 2004 and 2015 rose 300% in price. And while many people who are first diagnosed are not of the age of Medicare, this disease isn't fatal. People live with it for decades. So eventually they are aging into Medicare population and facing those catastrophic coverage prices that Congressman Courtney mentioned in his opening remarks, where they're paying 5% of drugs that are sometimes $80,000, $90,000. So HR 3 is a great first step in addressing the cost of drugs for Medicare patients as well as patients in private plans. And really working towards fixing a part of our healthcare system that is not working.
So, Laura, just to follow up on a point that you made, which I neglected to mention during the description of HR 3. So, as Judy and Nora have definitely attested, this change is going to have a huge impact on Medicare recipients, which is roughly about 50 million, 60 million, I guess, if you include people with disability, and in the system there. It also, however, will extend beyond that population to people who are on commercial health insurance plans, which again, that's about 150 million Americans. Okay, these are people who are on employer-based health plans, and as I said, the Connecticut Department of Insurance has, just using this year's current data, shows that 23% of those premium dollars are now consumed by prescription drug costs. The negotiated lower prices for insulin, Humira, take your pick, will actually be extended to commercial health plans in terms of them having the ability to purchase at exactly those same levels. So the bill amends what's called the ERISA Act, the Employment Retirement Income Security Act, which is the federal law that regulates commercial health plans. And I know, Laura, your population, again, consists of a lot of people below the age of 65, and I just, if you want to maybe sort of foot stomp that point a little bit, and also, talk about if people can't afford access to medications, as exciting as some of them are, I mean, it kind of defeats the whole purpose of what we're trying to accomplish here in terms of healing people from their conditions.
Yeah, absolutely. So in 2019, the median price for a brand MS medication was $88,000. So even when its price is negotiated, people are still paying very high rates for their medications, and we've heard from a lot of people in the state of Connecticut and across the country that the only way they can afford their medications right now are through copay assistance programs. And those aren't always available. They run out of money. They don't happen year over year. One patient that I know, her name is Pam, she lives in Connecticut, she's on Medicare. She was taking a drug called Atomex, and the first month she got her bill was $2,500. She couldn't afford it, as many of us could not. It's a lot to ask someone to pay in a month. She luckily found a nonprofit that could help her with a grant program that provided copay assistance, but without it, she would have had to stop taking her medication. And in fact, we did a recent survey of individuals living with MS, and 40% of them told us that they had changed the way in which they were taking their MS disease-modifying therapies because they could not afford the full cost, whether it be stopping taking them, rationing medication, and these medications are really the only line of defense for people living with this chronic illness or other chronic illnesses, between them and the permanent accumulation of disability from the progression of the disease. So when people aren't able to afford the medications, they stop taking them. So it's wonderful that we have this innovation. It's wonderful that we continue to see growth in new medications, but it's only wonderful if people can actually take them.
There's one unknown consequence that we've had to deal with at the Center for Medicare and for some of our clients who have multiple sclerosis and other conditions, but this is MS in particular. They can sometimes, if they need a nursing home stay, a skilled nursing facility stay, they have problems getting admitted because the nursing homes don't want to be responsible for the cost of those drugs, and they are under the way they're paid. And so people have problems not only taking the medication, but also getting other necessary levels of care because of the cost of the medications. So it's an extremely important point.
Yes.
I'm searching for my prop, which I just thought of, which is my EpiPen. Because we've been going around, this makes me think of it, we've been going around the state as AARP. The congressman just mentioned it because one of his great staffers stopped by a Norwich event we had recently, but we've been having happy hours around the state because sometimes you need to have a cocktail to be able to digest this information. But we've been asking people to tell their stories, because when you have a story about what it means when you can't afford your medication, it's much more powerful than letting pharma own the dialogue. So collecting these stories and hearing from real people is very important to us. So, when I get asked questions about, what's the impact, I like to go to my numbers because they're terrifying. But also, we've heard from a woman in Danbury, for instance, who needs a specific medication to protect her remaining kidney, and it's over $1,000 a month, and she simply does not have $1,000 a month. The EpiPen conversation comes up time and time and time again from grandparents, from parents. Like I said, my purse is a little full. It's hard to dig out my prop. But, I will die if I'm exposed to shellfish and I don't have an EpiPen. It's pretty hard to eat in, for instance, Groton without being near shellfish if you want to go to a restaurant, right? We've had people tell us about, they chose a high deductible healthcare plan because it's all they could afford, and then they're diagnosed with something mid-year, and now they barely can afford their deductible, and they certainly, can't afford the medication. And, this, like I said, is really important to tell your story, but I'll let the numbers speak for themselves. If 21% of Connecticut residents had to stop taking their medications because they couldn't afford them, I'll tell you that over the last few years, the same time frame we've been talking about, the extra dollars in Medicare alone that were spent, paid for by taxpayers, paid for by Medicare recipients, on medications that exceed the general inflation rate. Okay, so we talked about the inflation, but it's about $110 billion spent in what wouldn't have to have been spent if we had just seen prices increase at the general rate of inflation. But $110 billion is groceries for 25 million American families in a year. So we're talking about 25 million families who may be choosing between their medications and groceries. And, or we could pay for 9 million American students to go to college. But instead, what we're doing is paying excessive rates over inflation that make no sense in any world where we talk about research and development, we talk about CEO pay scales, we talk about all these items. So, there's real people stories, and then there's the numbers, and they're both pretty terrifying. And it's time to make these changes like HR 3 does.
Thank you. So again, we don't want to filibuster up here, and we have a hard stop at 11 o'clock. So at this point, again, we want to open it up to folks in the room that may have questions. Yes, sir.
Oh, great. Well, first of all, Congressman.
One second, let's get the mic.
Okay, good. Well, first of all, Representative Courtney, I I can't thank you enough. I'm a pharmacist, and I cannot thank you enough for what you're doing. And I really wish everybody would give you a round of applause. This is phenomenal, but this is a portion of the problem, okay? And we've got to all understand that right now, okay? Because there should be a few thousand people in this room right now, okay? Because drug pricing is absolutely out of this world ridiculous. But also, the access, the other side of the story is the PBMs, okay? Our health insurers that allow these PBMs to control our healthcare costs. Because remember, they're making money off of this too. So when we talk about the executives that make the EpiPen, we had the executive at a Caremark plan or an Optum plan, or you pick the Express Scripts plan, and they're making big money on the fact that drugs can be costly. And the higher the cost of the drugs, the more money they make because they get a percentage. Okay, and you got to understand that. Okay, there's a little thing called DIR fees that in one of my pharmacies last year took $360,000 from Higginham Pharmacy after the fact, after the negotiation, and brought it back to those shareholders. No more increase in cost of care. One little pharmacy with a town of 7,000 people, okay, they took $360,000 back from me, okay? This is a scary thing. It also, these PBMs also affect access, level playing field. I don't know if anybody's around Moodus, but in Moodus, Nathan Hale just closed, okay? Got purchased by a big box. Well, they also weren't going to go deliver to the senior centers, okay, to the senior citizens in the town. They bought it, took it out of town, and now they're not, they don't want to service the people in the town. They don't want to deliver. They don't want to do the little things. So this level playing field is very, very, very important, okay? This year, these PBMs just made every independent pharmacy a non-preferred pharmacy, okay? These are the pharmacies that are doing the Medicare review, just like the senior centers do to help you save costs. These are the pharmacies that are sitting there and listening and probably fronting you some medication when you can't afford it, okay? So understanding and bringing the PBMs into tow with this question and creating a level playing field is really kind of important. And I am so glad you're addressing ERISA, because ERISA is sort of like the law that they use. It's the big wide hole, big black box that they allow to do all these horrible things. And these DIR fees that I talked about, this is not the pharmacy's money. This isn't Higginham Pharmacy's money. This is the insurer that uses Higginham Pharmacy to take the money from Ma and Pa Joe Kettle down in the community. Okay, it takes their money because it raises the drug costs, and they take Ma and Pa Kettle's money. Okay, and remember, you talked about hitting that donut hole and the amount of money that you take out every year. Okay, that money with that increased drug cost, your money goes quicker. You're buying less drugs, right? And they're siphoning that. They're taking 9 to 11% of that money. This is real. 9 to 11% of that money. So you talk about an MS drug that's $88,000, and the PBM, the insurance company, not the pharma. The PBM is taking $8,000 back from the pharmacy after they dispense it, after the fact. And what we don't even realize is this insurance company, these PBMs that work for the insurance company, these PBMs also negotiate those rebate back money after the fact, after you've utilized the drug. Okay, so I can't thank you enough, and create a level playing field. Let local pharmacies be involved. Let us help you. And again, you lower the cost for everyone. What if everyone had a lower drug cost? What if those little families had lower drug costs along the way? They could put their money in education and run their families.
Well, thank you, Greg. And
Thank you.
Again, this is Greg McKenna, who operates an independent pharmacy, which is about as tough a challenge as almost as any sector in America. And we're very lucky because, again, they are really, for many people, the lifeline in terms of having that patient connection with people that's there. So the pharmaceutical benefit managers, the PBMs, as you pointed out, is something that probably, 10 or 15 years ago didn't even exist in this country. And really, it is another sort of collateral impact of high drug prices, because they make their money off of that sort of delta between the list price and what they negotiate for plans like Medicare Part D or private commercial health plans. So when you think about it, the impact of HR 3, which does not directly address some of the issues that you read, on the other hand, if it's bringing down the top line of drug costs, and again, the goal is to get it closer to an international price index so that we're in the same ballpark as countries like Canada and UK and France, then that actually reduces the percentage, because that's what they make their money off of, is a percentage of the discount. That actually reduces their presence. And again, just to sort of underscore that, they oppose this bill, okay, for obvious reasons because of that. However, we do have more work to do in terms of addressing that issue, and I just wanted to share with Greg and others that actually last week we passed two measures: the Public Disclosure of Drug Discounts and Real-Time Beneficiary Drug Cost Act, HR 2115, which and also the Payment Commission Data Act. These are bipartisan measures aimed specifically at PBMs to basically open that black box, and so that we can see clearer, what's going on here in terms of what are the size of the discounts that they're negotiating, what's the size of their fees. This is stuff they obviously want to protect and avoid disclosing as much as possible. They both passed by voice vote in the House, Republican and Democrats. One of the bills is Buddy Carter from Georgia, staunch Republican, who's a pharmacist, and he's living this. And so, again, your point is well taken. The bill, again, has a top-line impact, which I think is good, and we're going to keep digging more to sort of
I can't
get
think
our
of
arms around this.
Yeah, you're 100% right.
So, okay, yes, ma'am.
Oh, thank you very much for being here. I appreciate all of you who are advocates for senior citizens and everyone else. I'm just a concerned citizen here, and I want to know what I can do to get this from being an act to being a bill, right? We need to pass this bill. Is that correct?
Correct.
Okay, so what can the average citizen do?
So I get asked that question a lot. Again, as I said, there's bills that just get introduced and people hold press conferences, and then nothing much happens. I mean, again, I want to emphasize this bill has gotten through 3 standing committees in record time. And again, just in this past month of October, and really the next step in the House is to bring it up for a floor vote, which the Speaker has said it's her goal to get this done before the end of the calendar year. There is a bill in the Senate which is a much more watered down version of this. It has the rebate sort of piece in it, but does not have the price negotiation piece in it. But the fact that, frankly, there's a pulse over there is still a good sign. It really does show the political power of this issue. And by the way, the president, when he campaigned, talked about, we're going to negotiate like crazy with the pharmaceutical companies. I mean, this is something that I think really is in the DNA and the bloodstream of the country right now, which is that this is we're obviously, conceding something that could really help with a smart change in the law. So, the stories that Nora described, you should share them, if anyone has them, with my office, the 2 senators' office, if you're not from this district, the other member offices, and grab a card before you leave here. Maria Costigan in my office in DC can keep giving you updates. We're going to keep tracking this thing, and obviously connect with some of these advocacy groups here, because there's power in numbers. Sure.
Thank you.
So, I really appreciate you asking that question. We have a supportive delegation here in Connecticut, so the answer of call your congressman, it's not really that helpful for you, right? But I think what is helpful is getting the message out. And you all have an opportunity to help get the message out so that your fellow citizens understand, and then they're talking about it. So on Thanksgiving, instead of us all having a fist fight over politics, we can agree on something, right? We can all say, yeah, I do think I'm paying too much for prescription drugs. Yes, this is a problem. So I would recommend, there's a lot of data up there that we've all left for you. I would recommend letters to the editor. And I would recommend using social media for good this time of year. When you can share that this is out there and you can share it with your larger world, right? You reach beyond our delegation, which we're gonna get yes votes on this from our delegation, into places where maybe there's wavering. So that your friends and your family in other states can help continue to spread this message. Again, you cannot let the pharmaceutical industry and the lobbyists for them own the conversation on this, right? So I'll give you another stat. Pharma spent nearly $169 million in lobbying and more than $6 billion in advertising in 2018. All of our organizations put together don't have remotely that kind of budget, so we have to rely on real people. The 600,000 AARP members in Connecticut, the 38 million AARP members nationwide, all of your delegation, everybody who's on Medicare. So help that way, because we're lucky in Connecticut, but it also sometimes leaves us feeling like, well, what am I supposed to do? I've already got this. We need others to help.
The awareness level on this bill, I can just tell you, is pretty low right now. Again, it's just, and I'm not being critical of people, there's so much else going on in the news out of Washington that this thing has kind of gotten lost in the noise. And so Nora's point is absolutely right. We have, ways that are free, through letters and social media to kind of, tell people, hey, there's something real here that can actually change this unacceptable situation.
Good morning, Congressman Courtney, and to everyone who's here. My name is Yvette Heisman-Francis. I'm a Regional Vice President with Community Health Center, Inc. We have the office right over on Gold Star Highway here in Groton and also on Shaw's Cove in New London. I just want to say thank you, Congressman, for championing this initiative. From the primary care side, we provide outpatient medical services to really our community's most vulnerable residents. And when a medical provider has to pause and think about what their treatment plan is going to be for a patient because they know that individual does not have prescription coverage, really impacts the ability to care for people in a manner that delivers care with parity, and that will be effective. And as an organization, while we are a federally qualified health center and do have the benefit of access to 340B medication costs, there are still people who cannot afford to pay $150 a month, $350 a month for required medications. And so having the ability to ensure that all of our nation's citizens have access to affordable prescription coverage is absolutely critical. So thank you.
Great. Thank you for the great work your organization does. So, yeah. Anyone else?
Good morning. I was just curious whether you had any views on whether the Majority Leader of the Senate, Mitch McConnell, would bring H.R. 3 up to a vote.
Well, so, that question gets asked all the time, whether or not anything can move in the Senate. As I said, the fact that Chuck Grassley, who's the chairman of the Senate Finance Committee, which, believe it or not, has jurisdiction over healthcare, that kind of surprises people sometimes in terms of the way the rules work there, has been working on at least a rebate bill, which is part of HR 3, shows that even folks that have been pretty resistant to a lot of other measures that have come out of the House know that this one you have to handle with care. You cannot stonewall the issue of prescription drug costs because it is so widespread in terms of public dissatisfaction that's out there right now. So if you think about a scenario where we pass HR 3 out of the House sometime hopefully by the end of the year, and Grassley's bill, which got reported out of the Finance Committee, because his members are going to feel pressure to show that they're actually trying to address this issue. And the Democratic ranking member on finance, Ron Wyden from Oregon, has been, he likes our bill better than Grassley's bill, but he also understands, that sometimes you gotta sort of get something moving and to engage in a conference committee. I'm not, and by the way, Speaker Pelosi has been talking to the Trump White House about this issue in terms of the development of the bill. So it's tough down there. I don't want to, oversell things, but I would just say that unlike a lot of other issues, like gun violence or a whole other immigration, which are probably pretty stuck in terms of any movement in the Senate. This one, I think, actually is in a different place because of the political power behind it. As I said, red state, blue state, doesn't matter. This thing is really impacting people from every type of political district and jurisdiction.
One thought I had to add to Nora's and the Congressman about what you can do, and also I have to say as an aside, this is like it seems to me the at least fifth time that we've said, talk turkey at Thanksgiving, and this year's theme is, and it's often been prescription drugs, but if you have family from Senator Grassley's state, Iowa, or Senator McConnell's state, Kentucky, think strategically about where you might be able to have a letter to the editor or peer, and because maybe you have a cousin in one of their states, in the state of the paper of record. Also, questions for candidates, just so that we can start making sure that this issue and the issues of that Medicare is facing now, people with Medicare are facing now, get asked in all the noise about Medicare for all with the lowercase f or uppercase f. So think about where you have friends and family, support our congresspeople, and also think about as the elections proceed, if you're with candidates, it's a time to talk about this bill, but also the issue that it brings forward, which is the high cost of medications and the gaps in Medicare that need to be fixed.
Hello. You had said that the negotiated price that HHS would extend to those with commercial plans. Would it also extend to those who are uninsured?
So that's a great question. I mean, to the extent that prices are lower as a result of a negotiated price, I mean, there would be benefit there. But if you're uninsured, any out-of-pocket is a problem that's there right now. Again, we made some progress in terms of boosting people's ability to enroll in programs, like Medicaid if you're very low income. By the way, the enrollment period is underway right now for the Affordable Care Act year, and Connecticut's premiums actually came in a little lower than I think people expected. So that's all good, and there's still subsidies for people who are above the Medicaid level. But that population, again, it's still going to be a challenge for a lot of folks who don't fit into those buckets in terms of getting health coverage. But there's just no question that, to the extent we've got to get that top line of the chart that's there, that at some point this is going to have a universal benefit. It really will, in terms of just lowering costs across the board. And frankly, it will make the cost of addressing folks who are uninsured today, whether it's, and I see some of my friends here from the Medicare for All Coalition, or people who have other ideas, whether it's Medicare buy-in or public option or whatever, to the extent that you're lowering one of the biggest components of healthcare, frankly, it just makes the solutions to that overall more manageable.
All right, so as the brain keeps clicking away here, when we talk about what you can do, there's obviously this federal effort with HR 3, but there's also state efforts happening. And disappointingly, we were not successful in the last legislative session in passing any kind of meaningful prescription drug reforms. And that all happened for a variety of reasons, some of which were really frustrating. But we're going to be back at it in 2020, and by no means assume that the vote will automatically go the way people in this room might want it to, where we're going to do something to reduce the cost of prescription drugs. I feel confident we are, but it is the lobbying effort in Connecticut is no different than the lobbying effort at national. And it's not just Connecticut companies. They fly in from all over the country and probably the world on this. So when you're saying, what can I do, you can also think about your role as a Connecticut citizen, where that letter to the editor actually might make a big difference. There's nothing in, I don't think, HR 3 about pay for delay, for instance. So pay for delay, I'm familiar with that, where it's where the patent holder of the drug pays the generic manufacturer to do nothing. No competition. It costs billions of dollars a year for consumers. So I would love to go to work never and get paid a whole bunch of money to do nothing. But that's essentially what it boils down to in the simplest terms. So we are going to definitely be trying to push on some of this pay for delay prohibitions and changes to that, transparency, as well as Canadian importation, because we've got to start challenging this, and it's actually something the Trump administration supports, and that states like Florida and Colorado and Vermont all passed last year, and we weren't able to. So don't just think about your national engagement effort here. Think about your Connecticut engagement effort here, because there are good things that we can still do even if this bill passes as is in its great, perfect form, right?
And again, just the pay for delay, which is a really important issue, because people game the patent process in a way that no one ever intended. The patents were created to protect people just for a very time period, limited time period. There is another bill, HR 987, which is the Strengthening Healthcare and Lowering Prescription Drug Costs Act, which does deal with that. But again, as Nora said, this bill is intended to be very focused on just the top line costs of prescription drugs. Obviously Medicare gets a big boost out of it, but also commercial health plans and patients as a whole. One other item as we get closer to the end here is, as I said, the budget score that we've gotten so far is very impressive. $345 billion in savings over 10 years. And again, that number is actually going to go up as they dig deeper into other prescription drug costs that Medicare pays. Judy is somebody who over the years has dealt with folks who encounter the gaps that exist in Medicare right now. She mentioned it briefly in her opening remarks, and maybe I just wanted to ask you to sort of talk a little bit more about ways that we can improve Medicare and not spend all the $345 billion, but just these have been long-standing issues that your clients and patients that have come through your door.
Yes, thank you so much for the opportunity. And I'm happy to say that the chairman of our board, Judy Fader from Georgetown, who's a professor at Georgetown, testified in favor of HR 3 in Congress and did raise these 4 gaps, not just the Medigap kind of gaps, but gaps in Medicare that we hope are more than just a wish list. We need to use this money to strengthen Medicare, not just in some phrase, but in reality for the vast majority of people who want to be in the traditional Medicare program. Most of the recent improvements, small though they are, have occurred for Medicare Advantage, the private plans. And so we need to level the playing field with Medicare, the regular Medicare program. So we saw 4 areas that we hoped the Congress would think about as they think where to invest in Medicare as a consequence of having this much overpayment. That's why we have $350 billion perhaps. One is out-of-pocket costs in traditional Medicare. There is an out-of-pocket cap in Medicare Advantage. It's $6,700 a year, so it's not terribly low, but it exists, and there's no counterpart in Medicare, real Medicare. The bill would have a $2,000 cap on prescription drug, and so that's marvelous. We're very supportive of that, and we hope that soon there would be an out-of-pocket cap included in traditional Medicare, if not now through this vehicle, that it really needs to be thought of. There are specific gaps in coverage in Medicare, and we hope some of those will be looked at, and the bill does anticipate doing some of that. And then I mentioned that oral health care, which the Center for Medicare Advocacy is very active in. The statute has a prohibition against coverage for routine oral health and dental care, but the kind of care that's not routine and that's being denied by Medicare is really outrageous. And it's sometimes care that people need in order to have surgery, for example, or transplant, or cardiac procedures. The bill would include oral health in Part B, which is great, but it sets a different, I think, a worrisome precedent by having the copay be not the normal Part B copay at 20%, but rather at 50%. And we're afraid if new benefits come into Medicare, they may have increasing cost sharing. Hearing and vision, we do at some point need to tackle the long-term care issue somehow, at least incrementally. But this bill does have some oral, hearing, and vision, and that's wonderful. There's administration biases now that are diminishing access to home health care, even as written in the law. And we hope that Congress will at some point think about having a standalone access to a home health aid be covered under Medicare, which people are having more and more trouble accessing now. And this administration is steering people, it's factual, to Medicare Advantage plans and putting more complexity and the possibility of some benefits for some people who enter Medicare Advantage plans. And we hope that we will look to evening the playing field so that it's as easy to enroll in traditional Medicare and Part D as it is to enroll in Medicare Advantage, and that every time something is added to Medicare Advantage, it's added to traditional Medicare. And that could just be a global statement. And just also to invest in the long-term sustainability of the traditional Medicare program.
Any other questions?
Thank you.
Okay. So anyway, there's lots of material that we have over at the table, and these are organizations that I think welcome dialogue and input and questions. And as I mentioned earlier, people should not assume that the awareness level on this issue is high, because frankly it's struggling to compete with a lot of the other news that's out there right now. But I had an event in Lebanon not too long ago where there was absolutely, these were sort of active folks involved in politics and public policy, had absolutely no idea that HR 3 even existed. And I'm talking about 2 or 3 weeks ago. So I just sort of share that with you that we need to lift this. At the end of the day, public opinion is very powerful in terms of what moves the place, and I think, frankly, once the word gets out on this, public opinion will be very strong, because it's an issue that is just so across the board and so powerful. So, again, thank you to the Groton Senior Center for hosting this. I'll stick around for a little bit, but thank you for all this.